It's wonderful to be here. I'm going to just ask my co-moderator to introduce herself.
Hello, I'm Marloes Emaus from the Netherlands. Welcome everybody. I hope everyone is fit from the fit run this morning and will be in time here.
And I'm Carl Leroux. I'm a clinician scientist from University College Dublin. So it's a really great session, and I want to congratulate the scientific committee for really putting together an amazing program, and also for this session, to kick off the meeting. So I'm going to ask Ricardo Cohen to talk to us about the effects of metabolic bariatric surgery in patients with kidney disease. Ricardo is the previous president of IFSO and is also currently the chair of the clinical care committee of the World Obesity Federation. And that just shows you how surgeons are stepping into all of these roles. And it's really important that, he is leading the World Obesity Federation from a clinical care, and that's wonderful to speak about this topic. So Ricardo, over to you.
Thank you, Carol. Thank you. Good morning, everyone. Thank you for coming here so early to kick off the meeting. Those are my disclosures related. Some of them are very tied to this presentation. And we have 3 diseases converging to the same organ dysfunction, chronic kidney disease. So we got the main causes of CKD would be hypertension, type 2 diabetes, and obesity. And to halt or to remit the progression of CKD, we have several different alternatives like SGLT2 inhibitors, ACE and ARBs, GLP-1 receptor analogs, finerenone, and we have metabolic and bariatric surgery because our goal is to control or halt the speed of progression of the causes, diabetes, hypertension, and obesity. So the first question would be, does metabolic surgery actually work for chronic kidney disease? And the short answer would be yes, but why the yes? First, we deliver with surgery long-term weight loss. This is the SOS trial, 20 years. The 36 years follow-up of the SOS got similar results. Look at the green line, the gastric bypass. It delivers at 20 years around 24-25% of total body weight loss. If you look at the randomized control trials with comparing metabolic surgery with the best medical treatment at the time of the RCT, we can see here that MBS is great for glycemic control as well, and is really related to the magnitude of weight loss. And if you look at the third cause of CKD, hypertension, high blood pressure, this is the Gateway study where I had the privilege to be a co-author, where we showed that mainly in resistant hypertension, so those persons who take over 3 drugs for hypertension, the gastric bypass had better outcomes than the best medical treatment. So, and this reflects, again, this is the SOS. I think the SOS is the most squeezed study on earth. And yeah, this is one of their sub-studies on the progression of end-stage kidney disease, where at the long term, people who were submitted to surgery had less progression to end-stage kidney disease. And why that happens? Because metabolic bariatric surgery breaks the cascade of the progression of CKD. The first square on the left side of your screen is it's a retrospective series. However, they compared the results of halting end-stage kidney disease between GLP-1 receptor analogs, the first generation here, the liraglutide, and surgery was better to decrease the speed of progression of CKD. People submitted to surgery, mainly the gastric bypass in the center square, eGFR decline, the estimated glomerular filtration rate decline was controlled by the gastric bypass when compared to the medical treatment. And albumin reduction is our study that I'll show in a bit with more details, that surgery was better in decreasing albuminuria than the best medical treatment. So this is our study where Carol is you're going to see our names in all the slides almost, because we're generating some evidence on this field. We compare the 5 years outcomes of the gastric bypass versus the best medical treatment. It was 100 patients. All of them had microalbuminuria from 30 to 300 milligrams of UACR. All of them had BMIs between 30 and 35, and all of them were at early stage kidney disease. It's the only trial published so far that used for GLP-1 receptor analogs, the first generation, so liraglutide, and we use SGLT2 inhibitors in this cohort as well in the best medical treatment. And the gastric bypass, we kept ACE and ARBs, we kept statins, metformin, and of course multivitamins. And at 5 years, to be very brief, the geometric mean for albuminuria levels was 46% lower in persons submitted to the Roux-en-Y gastric bypass when compared to the best medical treatment with liraglutide and SGLT2 inhibitors. If you look at the other components of the endpoints, 90% of the persons submitted to the gastric bypass reached over 15% of total body weight loss sustained for 5 years versus 22% in the best medical treatment. Looking at the ADA triple endpoint, A1C, blood pressure, and lipid control, again, surgery had significant positive outcomes when compared to the best medical treatment. And this is a very busy slide. However, what we found here is that the metabolomic inflammatory pattern in the kidney, in the podocyte, was much better, was healthier in the gastric bypass group when compared to the medical treatment. Second question is, who responds best? And then with François Patou, who's sitting here in his group, and our group in São Paulo, we went through the clusters of people with obesity and diabetes, the 5 clusters of diabetes, and we focused on 3 clusters, the insulin resistance, the insulinopenic, and those with diabetes, moderate diabetes related to obesity. So those are the clusters, and we wanted to see who would respond better to the intervention, mostly the gastric bypass and the sleeve gastrectomy. So we had a marked post-op reduction of CKD stage in people with insulin resistance, which is very an interesting finding. And if you look at the eGFR improvement, which is tied, is related to creatinine, so it's related to the lean body mass, the muscle mass, we can see that eGFR improvement was greater in people with insulin resistance, the cluster of insulin resistance. However, weight loss, it's an association here. Weight loss was not interfering here because it was the same weight loss in the 3 clusters that we studied. So there's a hint, a secondary hint that yes, surgery may deliver a better improvement of eGFR in the insulin-resistant patients. And the question number 3, is it safe really? I could spend a few hours speaking about the safety of metabolic and bariatric surgery in CKD. But we did a meta-analysis and a systematic review of all randomized controlled trials published so far, and the conclusion was CKD, regardless of the stage, does not influence the outcomes and safety of metabolic bariatric surgery. So yes, surgery is safe and effective in those patients. And the question number 4, does metabolic surgery grant access to kidney transplantation? Depending on the country, there are some cutoffs of sending patients to transplant. In Brazil, the BMI, it's BMI based, it's not disease based. It's BMI because of the complication and mortality of the transplant operation. So in Brazil, it's 32, the cutoff, and the US is 34, depending on the state. I don't know here in Spain, but there are cutoffs for sending people for transplant, kidney transplantation. And this is North American statistics. Obesity is the 3rd leading reason in the US for not being listed, even listed for transplant. Because if we decrease 1 unit of BMI, we can increase up to 11% of the chance of the persons being listed. And with 2 very prominent nephrologists, we wrote a review at the American Journal of Kidney Disease when metabolic and bariatric surgery is indicated. There are 3 scenarios. Scenarios number 1, BMI is 35 to 40 without diabetes. We recommend starting with drugs, with modern OMMs, and if the threshold of BMI is not achieved to list the patient to a transplant, metabolic surgery is indicated. The second scenario will be BMI is greater than 35 or even greater than 40 plus diabetes. If there's no contraindication for surgery, go straight to surgery. So surgery is prioritized. And third, if you had a BMI over 35 or 40 and the transplant is not an urgent one, you should start with GLP-1 receptor analogs. If there's some suboptimal response or intolerance to the drugs, prioritize metabolic and bariatric surgery. So this is what Alexandra Kukla today, she is a nephrologist with a high position in the leadership of the American Kidney Society. So this is what it will be in their guidelines in 2026. Finally, metabolic and bariatric surgery for chronic kidney disease induce significant and long-term weight loss. It improves glycemia, blood pressure, lipids. It's a safe and effective option for CKD. It improves the inflammatory profile on the kidney, may halt the progression of CKD. The cluster of insulin resistance deliver the best response for metabolic bariatric surgery. It's a bridge to kidney transplantation. Thank you very much.
Thank you, Ricardo, and also thank you very much for sticking to time. We have some time for questions, so please come to the microphones if you would be kind enough just to introduce yourself and then ask the question. While we're waiting for people to come, please, Franco, if you go to the microphone. But while Franco's going, so tell me, Ricardo, are the nephrologists turning around to you and say, we do not want our patients to have metabolic bariatric surgery, or are the nephrologists saying, please help us, we want our patients to have surgery? Are the nephrologists fighting you, or are they asking for your help?
Asking for the help. The nephrologists are doctors who are not they're risk takers, because the average mortality on a dialysis center is 10% in a year. One of the best dialysis centers in the world is in France, in Paris. And they are really prone to refer patients to surgery whenever it's indicated. However, there's one caveat. They don't know anything about bariatric surgery. So what we need to do is to educate them, because most of them, when they say, well, we're going to do a sleeve for transplant because this is the operation of choice for a transplant candidate, they say, oh, yes, what's that? So what we need is to educate them.
So before Franco asks you a question, so let me ask you a follow-up question. So the nephrologist asking for your help, do you find that we in the bariatric surgery community, we are going to the nephrologist and asking them to send us patients, or are we afraid of having their patients because it will change our morbidity and mortality?
Unfortunately, we are afraid. Surgeons are afraid. I'm not a good example because I look for them and we did all the studies, but most of my colleagues, they are afraid of having complications in people with CKD, which we showed here. It's safe, it's effective. Okay, the mortality is 0.8% versus 0.009, but it's worth taking the risk.
Franco.
Congratulations again, Ricardo, for all this work. My question regards to the mechanism underlying the effect. So do you have any idea? Is it weight loss? Is it dysglycemia correction? Is it hypertension reduction? What is it?
I think the main mechanism is in the podocyte. It's an anti-inflammatory effect over the podocyte. I couldn't have the time to show the paper that we did together on the mechanisms, but if you look at, regardless of weight loss, there's something going on in the podocyte that avoids the filtration of the protein. So it's an inflammatory mechanism that it's fought by MBS.
Ricardo, Nick Cormus from Sydney. In terms of timing of surgery and then transplant, obviously people after their surgery, they're very catabolic. Is there any guideline you give to people as to we should do surgery now and then maybe wait 3 or 6 months before their next surgery, or it doesn't make a difference?
What I learned from the nephrologist is that it depends on the urgency of the transplant. So we did already in kidney transplants candidates, they were totally uncontrolled. So, and they were under dialysis, and we did operations in people under dialysis. They do the dialysis before the operation. They withdraw the heparin and then they clear the heparin. We do the operations, and again they are back into dialysis the day after. It's high risk of complications. We had complications, but it's worth taking the risk because the outcomes in the vast majority of patients is very good.
And maybe you can just tell us about the current study that you're doing at the moment, the randomized controlled trial. And I think that's also a really good example of taking a difficult question, and it is possible to do the level 1 evidence, as you have shown,
Exactly.
to really convince us to expand metabolic bariatric surgery. So just tell us about your CKD stage 3 study.
We're doing now a stage 3A and 3B study, so it's advanced kidney disease. We're comparing the best medical treatment, the current one. We only have evidence with semaglutide so far, with the FLOW trial. So we're comparing GLP-1 receptor analogs versus the gastric bypass for end-stage kidney disease. It's an ongoing trial. We're in the last third of recruiting. Patients are really tough. For surgeons, we see prescriptions with 15 drugs, 18 drugs. Some of them I cannot even spell them, but it's going well, the trial so far. Hopefully it ends well.
Well, we look forward to seeing and reading those results.
Thank you.
Ricardo. I'm now going to ask Francois Patou to step to the podium. Francois is from Lille in France, and many of you know that he is the father of the SOPHIA bariatric prediction tool. I think more than 1 million people have used that tool, so this is also an illustration of doing research with a real impact. But today we're going to hear one of Francois' first loves, which is about the liver.
Thank you very much, Karel. Thank you for the privilege at the podium today. So from the kidney to liver. So this is the next frontier for us. This is a disease which is advanced, which kills people. This is advanced muscle D. So we know muscle D, it's a very common disease. It's not a disease. Advanced muscle D, fibrosis, and MASH is a disease who kills. This is the target. You may have known that we have published several papers during the recent decades with this cohort of prospective study showing with double or triple biopsies, 1 year, 5 years after surgery, routine research biopsies. And this picture just gives you the full story. This is a lady, 62 years old, when she was operated, MASH, severe MASH. This is the same lady 1 year and 5 years later, from severe MASH with fibrosis to nearly normal liver. This picture, when it was first published 10 years ago, was nearly unbelievable for the hepatic surgeons. But now this is clearly confirmed by many studies, including a beautiful randomized trial. More recently, we were able to pick the very severe patients, those with significant fibrosis. And you have here the patient in this case, and you can see that even if there is very little number of patients with F4, meaning cirrhosis, because this was a contraindication for surgery initially in France, you can see that the patients that we had at that stage did not have cirrhosis 5 years later, 2 patients. So that's just a matter of things. Even cirrhosis can regress, but we'll come back to that later. At the end of the day, 2/3 of patients with advanced fibrosis, F2, the F2 kills people, have remission after 5 years. It's a bit slower than the MASH disparition, of course. But most recently, what we've been able in this cohort is that we were able to connect the early surrogate endpoint. People don't care about histology. People care about life. And so what we were able to do is to connect the surrogate early endpoint, remission of MASH, with mortality 20 years later, because I've been doing that for 30 years, so the patients are aging as I am. So here you have the 3 groups. Blue is the no-NASH patients, no MASH to start with. They have a better survival, as you can see. And the green and the red are the ones with MASH in the beginning, but the green have no MASH left at 1 year. The red, MASH was persisting at one year. And you can see that at the end of the day, of the road, there is a very significant difference. So making clear that if you get rid of the disease, you will have survival improvement, which is very important. And don't we forget that surgery is the only obesity treatment that reached this type of evidence. First of all, of course, with the SOS study 20 years ago. So this is today, this is for us, this is the classical hepatology guidelines up to date. You can see that bariatric is on the map. Bariatric surgery is on the bottom right. It's there. It is not super exciting because it is for the indications already there, but let's say that hepatology thinks that MASH is not a contraindications for them. But that's interesting. Don't forget that hepatologists are used to send patients for liver transplant. They are used to dramatic, efficacious treatment, so they're not like shy like diabetologists. So it's maybe a very interesting point to work together. But I would like just for the next few minutes to give you very recent unpublished data, which I think are important, is the choice of the procedure, because we don't know, nobody knows really. If you go with open evidence, when we could in Europe, now we cannot anymore, but anyway, or you look at the only randomized trial that we have, level 1 evidence, the conclusion is clear. 1 year after, kif, same thing. So sleeve gastrectomy and bypass, both highly effective, but don't forget, surrogate endpoint, no difference in clinical things at 1 year. So this is what it is. And many people think, yeah, but a sleeve is easier, and the pathologists like to do endoscopy. So everyone is pushing toward the sleeve. So we were asking this question. In our cohort, we focus now on 300 patients with biopsy-proven advanced MASH. MASH or fibrosis type 2. So really severe patients, 300. You can see that they were choosing by themselves or guided by us, but really it was at random for the sake of the study. And for even more match the groups, we did this new statistical thing, which is inverse propensity weighting that can really get rid of the outliers. And you can see that at the end, the drawing is speaking by itself. The two colors are exactly similar, meaning the patients were similar exactly in the beginning of the study. So what we found is that if you look at clinical outcomes, BMI, and this was known, most of them are diabetics. 2/3 of these patients were diabetic. So sleeve is a little bit less efficient. It's efficient, but a bit less than gastric bypass. This has been shown and shown and shown again. It is now clear. The more severe the disease, the more the difference is becoming obvious. Aging, type 2 diabetes, and others. If you look at A1C, French doctors don't do bad, so they put drugs. So even if there is no remission, they have quite good A1C because it's easier to treat someone who has lost weight. If you look at enzyme, liver enzyme, clearly there is no difference. But what we did now is we looked at the histology because we had histology, double histology in a subgroup of patients. And here you can see that it reached significance for the MASH because there were more patients, that clearly, even at 1 year it's visible, but at 5 years there is a more persistent remission of MASH. And fibrosis will follow, but it will take more time. So histologically, there is a difference. But of course, nobody knows that because it's in the liver histology. But that's what we did. We now did connection with the mortality long term, and that was striking. And we did 2 times for looking at that. That means that if we look at these patients and we carefully compare the 2 match group, they start the same. This is 20 years. The x-axis is 20 years. So for 3, 4, 5 years, nothing very different. But as long as you go, people are dying of MASH. And if you're not treating MASH with persisting efficacy, they will die of it anyway. So because it was so striking, look at that. The hazard risk is 3 times. So you're saving a lot of life by choosing gastric bypass instead of the number needed to treat was no more than 6 or 7. So that means it's really a very big difference in 20 years' time. So we had a chance to go in Paris with friends who had a similar cohort with liver biopsy to start with, and the same French system where you can connect mortality in every patient. We think same thing. They have less follow-up. Patients were less severe to start with, 30% diabetic, but same story. Very significant difference, twice less death in the gastric bypass. So this is, I think, an important message. But I was asked also to tell you a little bit about cirrhosis. So this is what happens sometimes. Brolin wrote a long time ago that nearly 1 out of 3 of us and 1 out of 1,000 patients have been there. So incidental finding of a cirrhosis at the time of surgery. This should not happen. This should not happen because this is important. You can understand that cirrhosis is a big risk factor. This is American data. First thing, when you have this patient experience, not of the surgeon, of course, but of the team, because it's a full team thing, it's really important. Look at mortality rate. So cirrhosis, even in high-volume centers, so the blue thing is 1%, 1.4% death rate. This is crazy. You know, we are used to 1 out of 1,000, so 10 times more. But look, if you are in low volume, this is 7 to 8% death. 7% death from the surgery. Don't go there. And of course, the compensation of the cirrhosis, I will go back very soon on that, is the massive point important. So if you are doing decompensated cirrhosis, those I will explain then, 22% of death rate. So this is just crazy. You don't want to go there. You want to escape that. This is impossible. On the other hand, the compensated cirrhosis, you are in the 1%. So it's more than normal patients, but it is very severe disease, and you are saving life at the end of the day. So what is to be done for decompensating cirrhosis exclusion? First, don't forget clinics. Clinic is important. Any clinical sign, ascites, jaundice, bleeding, any bleeding episode, encephalopathy, of course, is a no-way. Biology should be done, and the MEL score is really the very simple one to do, and it's used by all hepatic surgeons and hepatologists. If it's above 8, 5% mortality rate for cholecystectomy. Don't go there. And if there is any risk, portal hypertension, direct measurement, or imaging, or endoscopy. A single varus is a contraindication for surgery. You are in the decompensated with hypertension. So you have to be very careful. You don't want to play in this 5 to 10% death rate. So just to finish, this is just, I was asked also to give you a given word in these 10 minutes about liver failure after severe denutrition. It's another story. Many of these patients were not having MASH to start with, or maybe muscle D. But this is what we see. And you see that, because if you just stay there long enough, you'll see that. This was with OHGB 10 years before. The story is always the same. Malabsorptive surgeries, Copinaro historically, OHGB these days, many others coming. 10 years after, super result, two good results. Look at the thinny lady. Very incredible weight loss, but denutrition. This was COVID. It could have been anything, depression, whatever. Denutrition, protein denutrition. Prealbumin was nearly undosable. Acute liver failure, MEL was 27. This means that this is what you see. Look at the sign. Just put the ödem on the skin. This is the thing. If you see someone with that, this is death signal. You have to be very careful with these patients. Not only they are lean, but they have ödem. It means they have a very serious clinical condition. This is a CT scan. We can see ascites. You can see the hypersplenism. You can see everything you want. And what we had to do, liver transplantation. This happens. So this was done on this lady. So this is happening everywhere. This is case and case coming everywhere. Be careful with these patients. So to finish, just and summarize what I've just said you, resolution of advanced muscle D after metabolic surgery is possible. You can fix this disease, even if advanced, 2 out of 3 times. This is quite unmatched. Drugs are coming, but they are very, very behind. Not like weight loss, much more behind, and it's just starting. OHGB, this is my new message, and it's not published, it will be soon, but I think it's quite strong, is at the end of the day, have more weight loss, we knew that, better histological resolution, but better overall survival, significantly better. So for the severe patients, you need to have efficient treatment and efficient operations to fix the disease. And always just remain that's enough for the talk. Rule out decompensated cirrhosis before you go in any surgery. And with that, I'm finished, and I thank you for your attention.
Thank you very much. That's wonderful. Please do come to the podium. If you have some questions, please go ahead.
Francois, in the study that you looked at bypass versus sleeve and showed improved mortality, what are people dying of? Is it heart disease? Is it hepatocellular carcinoma? Or is it decompensation of their liver disease?
So I cannot tell you exactly because we don't have the cause of death in this retrospective study for every patient. We are gaining there. But I can tell you by clinical experience that most will die of cardiovascular disease. Most patients with MASH are dying of cardiovascular disease. The liver event is quite less often. And so that's my understanding. So, yeah, same as kidney.
So, Francois, there's some, a growing understanding, in obesity also that people are now talking about. They say, see obesity, think liver, treat the heart. And what you are saying is you are saying that metabolic bariatric surgery is, one of those solutions. See obesity, think liver, treat the heart, because that's, So also just talk to us a little bit about your other work about showing the 2 phenotypes of people with MASH, that have a liver phenotype or a cardiac phenotype, just for us to understand how important it is to actually get those messages across about, see obesity, think liver, treat the heart.
What I would say is that the liver is on the way. It's, in most cases, is a victim of the metabolic thing, meaning that it's a victim which goes very slowly. So the liver is a good window because it tells you when you can cure the liver disease, you're in good shape, you're on a good track. The thing is losing weight for 1 year. Okay, good. Many things can you just fast, you can do many things. But the thing with the liver, it doesn't cheat because you cannot maintain weight loss for 5 years easily. And if you don't maintain it, this is what happens with the sleeve. We know that sleeves are gaining weight after 3 or 4 years. Many of them are gaining weight. Then the liver effect is vanishing. This is why it translates in mortality difference at the end of the road. So I think this is really a good disease for us, because it's really a tough disease with a very clinically significant outcome, and a tough disease to treat. And surgery, by the way, is fixing it. So it's an interesting window, I think.
Okay. Maybe then the same question that I asked to Ricardo. So you work in a liver center. This has really been your interest. So of course, you know, the interaction between you and the hepatologists are different. But when you go out in France or out in the world, do you see many metabolic bariatric surgeons going to the hepatologist and asking for patients? You know, is this a missed opportunity?
I think it is. It is a missed opportunity, and I think that the hepatology, I just discovered obesity and diabetes a few years ago, but this is true. If you go to their meeting, I'm invited quite often now, and you can see they are just reinventing the multidisciplinary team, the lifestyle, and all these things. So it's really amazing. It's like 5 years beyond. But the thing is that they have not yet seen that they will never treat diabetes and obesity. Their job is to treat the severe liver disease. And for these patients, surgery is maybe the good answer, much better than the drugs. So I think for the common disease, they will fight with diabetologists and others to have these patients and prescribe drugs. But for their real patients, if they understand the results, they do transplantation, you know, they know what it is. So I think this is a good community to work with. But of course, it's a narrow group of patients, but there are many.
Thank you very much, Francois. Then I'd like to introduce Luis Osana Wilhelmi to the stage. And I think he hardly needs an introduction. At 7 o'clock this morning, he was already keeping everyone fit, and he's still running the business here to get everyone in the right place. So thank you very much for that. And really nice that you want to talk about bowel health here.
Okay, thank you very much. Thank you, Claire, to moderate. Thank you, Marlos, to prepare this very interesting session. And it's a real pleasure to be here, also with these colleagues surrounding me. Okay, it's very interesting because during a professional career, 30 years, 40 years, we have time to see the evolution of our work. I remember 30 years ago, we was worried about the patient to lose weight. 20 years ago, we will start talking about metabolic surgery. Seeing the patients with diabetes, they never take more drugs. It's very interesting because now if you go to an endocrinologist meeting, endocrinologists, cardiologists, pneumologists, they are talking about the patients cure their pathologies. And I remember 20 years ago when Francesco Rubino started talking about metabolic surgery, and the surgeon started talking about we restore chronic disease. So it's very interesting to have this session talking about other aspects. Because now we are very, ambitious. We are saving all the aspects of our patient, not only lose weight, not only restore the chronic disease, but what's the matter with the kidney, what's the matter with the liver, so important. What's the matter with the bowel disease? We are looking for an effect, trying to restore the disease, trying to lose weight, but at the same time, we are provoking another disease. So we must take care, especially with the bowel health in our patients. I have nothing to disclose. So as I show you, we radically transform the gut ecosystem, increasing the diversity of the microbiota. We are looking to improve the metabolic profile, but we can cause gastrointestinal side effects, independent the kind of surgery we do in our patients. Obviously, the metabolic effects is the more important we are looking for. If you see, as much aggressive is the surgery, as much as bigger is this metabolic effect. We have some change when we thinking about the bowel health in our patient. Changes in the gut microbiota, increasing, for example, proteobacteria, fusobacteria, and verruco microbiota, and decrease firmicutes. And this has a result promoting a healthier metabolic profile. But it's not only the change, it's a structural and functional modifications like reduction in the stomach and changing the size of the small bowel. What's the result what are the symptoms of our patient? A lot of. Most of the patients, 40% have flatulence. Constipation, especially in the first few weeks after the surgery because they are taking not so much food and the motility is slow. I think everybody here after a sleep gastrectomy, we are suffering so much because our patients are coming because the constipation. And also abdominal pain and nausea. I think we are calling this problem the chronic pain after gastric bypass. Maybe we think about another problem, maybe SIBO. Okay, and the more complicated problem is the long-term risks and complications. For example, dumping syndrome. Sometimes it's not so easy to restore. This is the rapid entry of the stomach into the intestine in our patients after, especially Roux-en-Y gastric bypass. Nutrient deficiencies, especially in a bigger surgeries like CDS, OGB, duodenal switch. Also short bowel syndrome. I think more than 40% I put in this slide. And serious complications like an ulcer, especially in gastric bypass, fistulas, especially in sleep gastrectomy, or portraying malnutrition. Okay, in our group in Malaga, we start thinking about we are doing something in our patients 30 years ago when we were making open Scopinaro for a lot of patients. This is not a randomized control trial, it's just we remove the appendix, half of the patients, just in case it's comfortable to do it. So 12 years later, we take samples of stool of our patients and we discover something very interesting. As you know, the Darwinian view about the appendices as a vestigial organ is going to disappear, in contrast to the result of our study. It's like the safe house. It's like a reservoir of healthy microbiota. It means maybe inside the appendix we have a healthy microbiota waiting for a dysbiosis trying to grow. So our patients who remove the appendix, they have a very poor microbiota. If you compare with the patient, is still with the appendix. So maybe we should consider microbiota in a practical surgical decisions to decide what kind of technique we are going to make to every patient. Maybe a patient with a big problem, previous SIBO, previous, etc. Maybe must to take care about to make a big surgery, maybe and another to decide another surgery. So how about SIBO? I'm going to talk for the next 5 minutes I have, especially about SIBO, the spectrum of small intestinal bacterial growth. As you know, the microbiota is just an harmony. It's an equilibrium between the microbiota, the microorganisms, and the body of the patient. When this harmony disappears, this imbalance produces SIBO. As you know, in the stomach we have 10 power of 3 cells, microbial cells, to the 10 power of 12 in the rectum. In the middle is a small intestine. The problem for SIBO is this growing for some reason after the surgery. How about the epidemiology? If you go to the American College of Gastroenterology, the clinical guideline, there are many mechanisms to maintain the homeostasis in the small bowel: gastric acid, pancreatic enzymes, bile acids, small bowel mobility, ileocecal valve to maintain the ileocecal valve, and the immune system. What's the matter? Okay, there are many reasons to lose this balance, this harmony, and the more important thing is post-surgical cases. I'm going to explain you, many digestologists don't believe SIBO is growing. SIBO was described 40 or 5 decades, but now many people is talking about SIBO. I think the reason is because of the bariatric surgery. Maybe we have to talk about 2 different syndromes: primary SIBO and post-surgical SIBO, or post-metabolic bariatric surgery SIBO. They are different. So should we treat all the patients with SIBO? We need an statement, we need a position paper, and the Spanish Society of Digestology make with the Association of the Neurogastroenterology and Motility in Spain. And they conclude in 5 points. Most patients with non-specific symptoms do not have SIBO. Maybe for private practice, everybody has SIBO. Maybe 80% of the population have some problem after they take a heavy meal. But this is not SIBO. But maybe in the private practice, instead, in the public system, it's a very attractive right now to make a lot of tests, brief tests, and to give treatments without evidence, as I'm going to show you. We recommend SIBO just for patients with risk factor like intestinal bariatric surgery and motility impairing conditions, not to everybody, just for these patients. We prefer breath test with glucose instead of lactulose. And I was asking to some of my colleagues, diastologists, most of them use lactulose, but this statement prefer glucose to do this test, as I'm going to show you. And it goes to analysis by specialized medical staff, not to everybody, because you need to know so much about this problem to be sure you are making the good diagnosis previous to give treatment to these patients. And systematically, antibiotic use should be avoided, not for everybody, just for risk patients like after surgery or impaired motility, as I told you. So the mechanism is not only bariatric surgery, it's also the migration antegrade from colony bacteria to the small intestine, especially when you make a resection of the ileocecal valve or maybe when you make a Roux-en-Y gastric bypass. Okay, the guideline of also the American College of Gastroenterology, they make a graded model reconstruction for SIBO, and they decide 6 points to study, and all the recommendations are very poor. Conditional recommendation and very low level of evidence. Just in case of treatment, is not very low, it's low level, but instead, it's not a good recommendation. This is the breath test, we have to do it. The normal breath is normal, low to 10 parts per million. When you make the hydrogen predominant SIBO, it's higher than 20 per million is positive, and if you go to look for the IMO, the metanogen overgrowth, is higher to 20. Okay, what's the matter with the main techniques we use? After a sleeve gastrectomy, this is a very good paper from the Scandinavian obesity surgery. They compare more than 64,000 people. Looks like increase the possibility of ulcerative colitis after a sleeve gastrectomy. Also, after sleeve gastrectomy, constipation is very common. And in this work, in adolescents after a sleeve gastrectomy, we can see the potential inflammatory phenotype to increase, also elevated fecal calprotectin, but also increased incidence of inflammatory bowel disease. When we make a Roux-en-Y, we can see rises to 40% from 50% the SIBO in our patient. Also, thiamine deficiency is so important in this patient. And it's associated with severe hepatic steatosis. But this is absolutely clear. Everything happens in the small intestine, the liver knows. We have a big highway, 1,005 millimeters every minute going through the intestine to the liver. This is the portal vein. So everything happens in the small intestine. Immediately, the liver, the hepatocyte, knows what's the matter and is going to suffer the problem in the small intestine, the main hepatocyte. This is another work increasing. As much time goes, you have more possibility to have SIBO. In this work, previous 3 years, just 29%. After 3 years, 53%, they are going to have SIBO. Okay, this is another work, the same of the Swedish group. This is not increase ulcerative colitis as sleeve gastrectomy, is going to increase Crohn's disease. The most important surgery, big surgery, sorry, is OEB on duodenal switch hand problem. This is a work from Portugal. They compare 3 periods, previous 6 months to 12 months, and 1 year to 5 years. In going to increase, to changing the problem. First month, nausea, next month, low defecation, and definitely constipation after 1 year to 5 years. Other problem is to increase the SIBO when you make this surgery. I'm going to finish just 1 minute. What's the matter with the treatment? Okay, the antibiotics. I think it's the only treatment the diastologists believe is going to work in some specialized and individualized cases, not to everybody. Maybe antibiotic non-absorbable, maybe rifaximin, as we use in the diverticulosis, as you know, and maybe another systemic antibiotic like ciprofloxacin, like trimiprazole, sulfamethoxazole, and other, but with a very low evidence. How about diet? Okay, obviously we have to try to reduce the fermentable products and also low FODMAP diet. So fermentable oligo-monosaccharidos and polyols, trying to take low. Fecal microbial transplant, there is no many words talking about it. It's limited study, and used to be based on lactulose breathed teeth. The FDA warning about the multi-drug resistant microorganism passed on the recipients during the fecal microbial transplant, and is published one case of severe constipation after Clostridium difficile patient. How about prebiotics, also especially probiotics and symbiotics? Okay, you can take the literature. There are many words talking about it, but with a very low evidence. Thank you.
Thank you very much, Luis. We have time for a quick question. Someone in the audience? What do you think that is the first thing we have to do with our research on SIBO or bowel health? What is the first main goal?
I think in the previous turn of question, you make, Carol, a very interesting question. We have to incorporate in our multidisciplinary team not only basic researchers. We have two. We are I'm very proud to have an basic investigator in my team, but also a diastologist, specialist in neurogastroenterology and motility. We have endoscopist, trying to avoid the complication we have in our patients. We are now on hepatology, talking about patients, as Dr. Patu told, to make the decision when we make the bariatric surgery, when we make the liver transplantation, when we don't make anything. Depends the male, as he explained. And also we have to incorporate something talking about motility, because I think SIBO now, in my opinion, is so important, especially for us, for surgeons, to understand. If you want to be, in my opinion, better surgeon, you have to know all the epidemiology, all the physiopathology. What's the matter after you make? This is not just to change the size of a small bowel to reduce the stomach whenever. You need to know pretty much what's the matter later. Not maybe the first 6 months, what's the matter 10 years later. So maybe we are making some redo surgery, and the problem is maybe not to make another surgery. Maybe it's to take care about SIBO. So in my opinion, research and to incorporate in our team a neurogastroenterology is absolutely crucial.
Okay. Thank you very much for your talk. Then I'd like to invite Cătălin Copescu from Romania. He's a very busy man these days as president-elect, but I'm really glad that you are here to talk about post-bariatric hypoglycemia.
Well, thank you very much for the kind invitation, and I'm gonna try to tell you some update about something that you all know. I mean, it's post-bariatric hypoglycemia is something that we are searching for always, or I think this is in our patients, or nothing to disclose in this respect. So I'm going to look a little bit to the incidence diagnostic, a little bit to pathophysiology, and then ending up to the therapy that it is to be highlighted as update for hypoglycemia. Nowadays, very well defined, the post-bariatric hypoglycemia got at a prevalence that it's higher than we expected. And I think this is the first update we have to look at, because we know from the registries that it's really, really very low. But in fact, in our experience, we were seeing that the patients got symptoms much often than it is in the registry, below 1%. So that's not always the clinical symptoms related to what you can get with accuracy by continuous monitoring. But it's something that it's there more often than we expected. And we know that not only bypass with high numbers is there influencing the glycemia, but also sleep, which was supposed not to be that much influencing the postoperative glucose level. Now we are, and I think this is another update, we are able to list the risk factors that might influence the post-bariatric hypoglycemia. And I think this is very important because a female, of course, a Roux-en-Y gastric bypass being at a higher risk for developing post-bariatric hypoglycemia, but also the patients without preoperatively diabetes. So if they did not have diabetes, there is a higher risk that after the surgery, they will develop an exaggerated reaction of GLP-1, and we will see later on how. Now, we know that consequences of late dumping syndrome, of post-bariatric hypoglycemia, we know very well the impact on quality of life and the social, professional consequences, the risk of accidents that it is valued 2 to 7 times more. And we know also the SOS study that it's pointing toward the Roux-en-Y gastric bypass increasing significantly the risk for any kind of fall. So we know this, and we know that a large number of patients are undergoing bariatric surgery, and putting this in the context of numbers that I've just showed you earlier, that's important for the clinicians to identify who will need a therapy in this respect. Because at the time of diagnostic, which occurs, I mean, the symptoms are coming later after the surgery, it's most probably that the patients are discharged from the post-surgical follow-up. So there are no surgeons, no bariatric teams around. So the clinicians should identify which are the symptoms. When they occur, they should differentiate the early to late dumping syndrome, which is not always that easy for the clinicians, that they do not focus exactly to what happened 5 years or 6 years ago for that very patient coming to their office. They need to know that sometimes early and late dumping syndrome can be together, and only in few cases, only the late one is alone. Now, having this said, they need, when the diagnostic is there, they need to score the symptoms. But at least for the clinicians, I think it's important to identify at least the level of the impact of the hypoglycemia. And then, as diagnostic is pretty clear, it's crucial the symptoms to identify. Then the gastric emptying symptoms tests can be useful because it's part of the mechanism, but are not useful for the diagnostic. OGTT is still the preferred dumping provocative test, while mixed meal tests are less accurate for the diagnostic. And the continuous glucose monitoring will be on the time of therapy. Now, I think this is an interesting update for the medical community because the Society of Endocrinology offered the guidelines that it is trying to help the non-bariatric physicians, I mean the clinicians, and I think it should be worked probably more. Our association should do even more than this because there is an algorithm presented there how to rule out when the patient got symptoms. The Whipple triad, and then you rule out any other possible causes, drugs, and insulinoma. And in this framework, the question if it was or not a bariatric surgery is addressed only in the end. So that means that this is an algorithm that it was adapted somehow for post-bariatric hypoglycemia in such a way. But I'm underlining the importance of these guidelines. Now, before touching the mechanism, Before touching the therapy, there are some updates to the mechanisms. You all know this cascade. I will not insist to. But now we can confirm the important role of GLP-1 much more as the antagonists are there. So I'm naming here the avexitide, that there will be an interesting help for our patients. Also, there are interesting studies in the bile acids mechanism involvement. That's very important. And the therapy got not that much update to the initial input of us as clinicians when we see a patient with the symptoms. And not only that much to the medication that we're currently offering. We start with acarboses, and we have the sandostatin analogs there. But I will highlight a little bit about the GLP-1 agonist, that it's something interesting to look at the SGLT inhibitors and the analogs of glucagon. So that's interestingly, the GLP-1 agonists were proposed to be a theoretical tool more than 13 years ago. So that's, it was an interesting study, very good results, but not that many used this drug for our patients. And we have here Karel, his group looked at a few years ago how many they could collect patients that receive GLP-1 agonists for post-bariatric hypoglycemia, and guess what? They were very few. But despite this, they were able to look at the possible mechanism that can non-intuitively block somehow the GLP-1 agonists, which are the main responsible for the reaction with high insulin production and then the hypoglycemia. And I mean, how we can influence by adding more GLP-1 to that very patient that is suffering because of the GLP-1 reaction. So that is very interesting. And thanks to your group, I think that there were very interesting ideas placed in this scenario, and how the GLP-1 can block and keep busy the receptors, and then there is cooling down the reaction, the insulin reaction, and as a consequence, less hypoglycemia after. That's very interesting. We have to look at more. We have some experience in this respect, not with Roux-en-Y gastric bypass, but with patients with re-sleeve, because we were accelerating more the transit. And by treating them with GLP-1 agonist, semaglutide in this case, we could demonstrate a significant reduction of the symptoms and not only the 6-CAS score. There's some other things we have to look at. There are the SGL, the agonist increasing the expression. And of course, we have something to treat at in the crisis. And I think this is very important. And the studies showed that we have a tool to block the reaction that is sometimes dramatic to our patients, which is dasiglucagon. Now, I mentioned earlier the avexitide. That's probably something very interesting. Now we have the PREVENT study results, only a few patients. Now we're waiting for lucidity with more patients. And I think this is something very important for our patients, because we have something that we can really efficiently prevent the reaction, the post-bariatric hypoglycemia. And you can see here that only the placebo was below, the variations were that important after the meal. Whereas with the therapy, we're very well controlled the level 1 and level 2 hypoglycemia, and they're looking for the results. Endoscopy, it seems that it's bringing more help for our patients. Torre got already short and long-term results. We are waiting for more than 1,000 cases that are collected, I've heard these days. So there are already algorithms in this respect, and it seems that at 2 years, the results are stable, which is very important for something that we can add as restriction pretty easy. And also for a sleeve, you can place before the pylorus some clips there to reduce the. And in the end, the surgical input. Surgery was identified as the only tool for many years, a stable one, and the pouch restriction was proposed for many years, but before we need to test somehow with a feeding gastrostomy or a jejunostomy even as a therapy. For placing a bed, I didn't see in the literature that much progress. This was 13 years ago. That was an algorithm proposed at that time, but not that many are using this. Because probably we have Torre. But there is an interesting case report coming from the Bruno Dillemans group. There's a patient on her arthroatide, and she had to halt the therapy because being pregnant, and they did a modified Nissen fundoplication, and the results were very good in time. So it was a simple operation to restrict the output. Now, in terms of surgical therapy, there are studies showing that the improvement is significant, 88%. No discussion about any pancreatic resection. I think there is no need to go there. But I would highlight a few things about a study that is involving some of you here in the audience. There are many cases collected of reversal gastric bypass from many centers, and they could collect only 48 cases, which is a pretty low number, and only 30%, 33% were due to post-bariatric hypoglycemia, which means that it's really a very low incidence or need to do something for these very patients. And they are nicely presenting the way they did it with a high number of complications. I mean, the overall of 50% rate of complications, any kind of complications. And then we have also long-term in this study. They are very well presented with very good results in time. And I think here the update will be the robotic surgery, because especially for these cases, adding the importance of the technology that are helping the patients. And we have, not specifically for post-bariatric hypoglycemia studies, but for sure for revisional gastric bypass, an advantage of bariatric surgery. And I think this is the way to go. That's a case 20 years after an open gastric bypass, which is pretty very easy, whereas bringing the emotion in this respect and it's helping by the robotic surgery. And with this, I'm gonna come to the conclusion that I think that it's a serious prevalence with post-bariatric hypoglycemia. The risks were highlighted in the updates on therapy, especially, and for the surgery, robotic surgery. And with this, thank you very much for your attention.
Thank you very much, Katalin. Unfortunately, we have no time for questions.
Okay, thank you.
I'd like to introduce Lisa Tolvanen from Sweden. She's a well-known dietitian and knows everything about nutrition. She's gonna enlighten us about critical vitamin deficiencies.
Okay, thank you so much for the introduction and the invitation to speak on this occasion in this conference. Maybe this one is better. Okay, let's start. I have nothing to disclose. And as you all know, there are very much benefits with bariatric surgery for health, quality of life, and survival. And advances in surgical techniques have improved safety, but still complications can occur, particularly when it comes to micronutrient deficiencies, mineral deficiencies, and also vitamin deficiencies. And we are now going to focus on vitamin deficiencies. And what are vitamins? Let's start with basics. Vitamins are essential, required in small amounts for normal metabolism, growth, and physiological function. Since the body cannot produce sufficient quantities on its own, vitamins must primarily be obtained through the diet. Of course, supplements are also important in bariatric surgery. Although they do not provide energy, vitamins play critical roles as cofactors, hormones, and antioxidants in numerous biochemical processes. They are vital for immune function, neurological health, vision, bone metabolism, and blood coagulation. When vitamin intake or absorption is inadequate, deficiencies may develop, potentially leading to specific clinical syndromes, some of which can be severe or irreversible. And as I think all of us are aware of, bariatric surgery is associated with micronutrient deficiencies as well as vitamin deficiencies, as highlighted here. Bariatric surgery alters gastrointestinal anatomy and physiology, which can impair nutrient absorption, especially after procedures with hypoabsorptive components. At the same time, long-term micronutrient status is strongly influenced by postoperative diet, food choices, and adherence to supplementation. This makes micronutrient deficiencies both in obesity and after surgery clearly multifactorial, involving pre-existing deficiencies, but also surgical and after surgery behavioral factors. Importantly, even uncommon deficiencies may have clinically significant consequences. So, rare vitamin deficiencies, what are they? I should say that vitamin A deficiency is maybe the most well-recognized rare deficiency and may lead to night blindness and xerophthalmia. And of course, there is more increased risk for after these more hypoabsorptive procedures as SADI or duodenal switch. And also vitamin E deficiency and vitamin K deficiency are also rare, but may occur with fat malabsorption, affecting neurological function and coagulation. Thiamine deficiency is of particular concern, and as it can develop early after surgery and may lead to Wernicke's encephalopathy, especially in patients with persistent vomiting and or inadequate intake. Deficiencies of vitamin C and B6 are rare and typically related to prolonged inadequate intake or inadequate supplementations, although uncommon, these deficiencies can have serious clinical consequences, highlighting the importance of risk-based screening, supplementation, and lifelong follow-up. And this rapid systematic review nicely presented 83 cases of rare micronutrient deficiencies occurring more than 2 years after surgery, median 8 years after surgery. And most commonly, these rare deficiencies occurred after gastric bypass or pilopancreatic diversion in this report. Vitamin A deficiency was the most frequently reported, deficiency, while vitamin E and K were less common, but still clinically relevant. And clinical presentation range from ocular or neurological symptoms to hematological complications, and in some cases resulted in permanent disability or even death. Key contributing factors included, of course, poor adherence to supplementation. This is important for us to remember, but also what is our task as clinicians to offer follow-up. Inadequate follow-up was also one of the reasons for these deficiencies, or delayed recognition of deficiencies. Besides monitoring blood tests, I also want to highlight this nutrition-focused physical examination, because it provides us important clinical cues. Eye symptoms, such as night vision problems, dryness, or corneal changes may suggest vitamin A deficiencies. Neurological signs, including gait instability, peripheral neuropathy, or confusion, should raise suspicion for vitamin B and E deficiencies. Skin and oral findings, such as easy bruising, gingival bleeding, or poor wound healing, are often linked to vitamin C or vitamin K deficiency, while more pronounced bleeding symptoms may point specifically toward vitamin K deficiency. Importantly, these clinical signs are often late and non-specific, so it's essential to maintain a low threshold for monitoring and supplementation. So, what should we do? The clinical implications are straightforward. First, patients should be screened for micronutrient deficiencies before surgery, as many of our patients already have subclinical deficiencies when they seek bariatric surgery. Second, any identified deficiencies should be corrected preoperatively to optimize nutrition status and reduce perioperative risk. Finally, long-term outcomes depend on structured, lifelong follow-up with regular monitoring, early detection, and individualized supplementation. And it's also important to pay particular attention to high-risk patients, as they are more likely to present with deficiencies to develop complications. Thank you.
There is some time for questions from the audience. Yeah, François.
Thank you very much for important messages. These deficiencies sometimes goes with anatomical differences with surgery, but sometimes they just go with fasting. So what happens with the drugs? Because these drugs are making people fasting. So what are these deficiencies that we will find with drugs?
Yeah, that's a very good question. And I think there are a lot of research ongoing at the moment. What happens with GLP-1 treatment and micronutrient deficiencies overall. And I think we have to be aware of that and think of that. And specifically, if we put our bariatric patients on GLP-1s, they are maybe at increased risk to develop deficiencies.
But do you have any specific data, for example, for the most devastating one, which is B1? B1 is a disaster for patients, B1 deficiency with disaster in young patients. Do we have any data about the numbers, the risk after GLP-1? Is there any cases? There is very little publication about that. It should be, because there was with banding, so there should be.
Yeah, I know there are some studies showing that that this is not bariatric patients, but I remember now in my head. So it's new deficiencies. It's about 20% risk that you develop new deficiencies during 12 months of treatment. But that's one study I remember. But we need more research on that, and that's important. Thank you for your question.
I have one question. More and more we see that gastric sleeve is performed in worldwide, and sometimes I think that the reason is that surgeons and people think that there is not a problem and you don't have to follow up. What do you think about vitamin deficiency and severe or rare vitamin deficiencies and sleeve gastrectomy?
That's a good question also. I think we should follow all of our patients similarly and perform monitoring and supplementations recommended for both.
Because you also see that in gastric sleeve.
We can see that also in those patients, because it's not only, it's also the intake that affects what we are eating and how we supplement.
Yeah, okay, thank you very much.
Thank you.
Maybe we can throw this open to all the panelists, if we can throw in, and also to yourself. No, please stay here, but maybe you can start, but I want to ask the other speakers as well. So this was really, this talk was about the intersection between internal medicine and metabolic bariatric surgery. What do you think from a dietitian point of view? Do you see many dietitians referring their patients for metabolic bariatric surgery? Or is it only dietitians that work in metabolic bariatric surgery services that are positive towards surgery?
Of course, that's we should ask dietitians.
But what do you think?
Yeah,
I appreciate we don't know, but what's your opinion?
I think that dietitians are positive for different kinds of treatments for obesity, because obesity is chronic disease and complex. But of course there are individual preferences among dietitians also what they think. But I hope at least that we are positive and also suggest referrals to surgery. And we, as in Sweden, dietitians cannot refer to surgery, but we can suggest.
Okay. Maybe, Ricardo, Francois, as well, maybe you can come to the microphone and say, which internal medicine doctors do you think are the best ones to engage with? Because I think we've all realized that diabetologists are the worst internal medicine doctors. We did 13 randomized controlled trials. We showed level 1 evidence, and the referral rate did not change for people with diabetes. So which are the right internal medicine doctors to speak, or is it primary care doctors that we need to speak to show this incredible evidence?
If I could put this on tiers, I had the primary care physicians should be taught that surgery is an option, safe and effective. Most of them don't know what is bariatric surgery. Second, cardiologists and nephrologists on the same level. Cardiologists are, as nephrologists, they're not averse to risk because they see people dying. We surgeons are not used to see this, but they are. So I would focus on primary care physicians, but teaching them the basics, teaching them what is surgery. We don't kill 10% as they think. Surgery leads to long-term effects and works with medications. So I think this would be the pattern. And your question about the dietitian, I can tell you, dietitians outside the obesity field, they do not refer to surgery, never. It doesn't ever go through their minds that surgery exists. So we have a lot of work to do, and we've been preaching this for the past 20 years, but it's still an ongoing task we need to do, is to educate primary care physicians, nephrologists, cardiologists that it's an option, and mostly to highlight the safety of the procedure, and the safety plus working with medications to deliver the best long-term outcomes.
Okay, Francois, maybe from your perspective as well. So we see that obesity medicine is going rapidly into primary care. It is impossible for hospital doctors to treat obesity in 25% of the population. It has to happen in primary care. So, what do you think about the interaction between surgeons and primary care physicians? Is there an opportunity to actually, because most people in the audience will tell us their business is down 20, 30, 40%, depending on where you are. So whatever you are doing is not working right now, right? So what do we need to do better, when it comes to conversations with primary care?
So that's a tough thing, an important point for the community. What I think first is that we have to realize that maybe surgery, because it was alone in the dark, so it was easy. Any patients could come, there was no alternative. Now there is an alternative which is okay, which is good, not perfect. We've seen many important papers, BMG, very recently, where you see that everyone is not only coming back after stopping, but getting worse than before drugs. So there is data that will show that it's not the end of the road. But you have to admit that any patients, and we've done that in France, surveying thousands of diabetics for the metabolic surgery. Why don't you go there? What do you think of metabolic surgery? There are many answers, but the patient's perspective is first that they don't like the idea of surgery. Second, they are afraid, the simple idea. Second is they are afraid. And last one, they don't believe the miracle thing we are telling. They don't believe it. So the thing is that what I propose is that we really should be careful about going back to the good indications and the discussion yesterday about the classification and the definition. I think there is several types of obesity, and surgery is not for the mild one. This is obvious, and we won't see any more patients with a BMI 37, and no, it will disappear. But on the other hand, there are tons of patients who really need an efficient treatment that we don't see. So I think we have to be careful. I would be brief. Safety, keep it simple. Safety is really important. Keep it simple and just focus on the right patients. This is what I think we should do, but we don't know. In France, what I can see is that, France was special because we offered freely, this is the French system, to 8,000 patients, GLP-1 analogs, paid by France. So it was a first cohort study, so semaglutide for free. So, of course, it was very successful. And after 1 year, the French system didn't understand that it was for 1 year, and it was not paid after. So there was a lot of yelling, and after a few months, it was, okay, we'll go back for 2 more years for these 8,000 patients. 3,000 came back to get the drug freely. 3,000 of 8,000. That means that is only 1 year later. So I think these patients will come back to surgery. And what we see now in France, where surgeries go back again, France is the 3rd country in the world, after America and Brazil in terms of number of patients. And we can see that we now see patients after drugs, meaning someone refused surgery, took drug, and is back to surgery. Reminds me of the band story. Oh no, gastric bypass, no. Banned, because it is safe, but 5 years later, the same patient comes back, gastric bypass. I know what it is to lose weight, I want to go there again. So, I don't want to be optimistic, there is only count is the patient, so what is good for them is good for everyone, but I can see that surgery is good for many of them, but we have to be careful. Sorry, I was too long. Safety, and better indications, focus on more severe patients. That's where we are heading now.
Thank you very much. Every presenter, thank you very much for your presentation. It was really enlightening us about the crossroads in internal medicine and the bariatric surgery. Thank you for your attention, and we really hope you have a nice day and be inspired the rest of the day.